So on this one, we're gonna fly through this. The beginning part will be a lot of just a review that we did before. The big thing with sugar, again, hyperglycemia causes micro macrovascular problems and neuropathic problems. So I'm just going to highlight the main things on these slides. There's a lot of words. I have to clean them up, but we're just going to zip through really fast. So unlike type 1, type 2 are not absolutely dependent on insulin. It's not until they burn out their stores, all the beta cells, then they become insulin dependent. Hyperglycemia from endogenous insulin, which is the problem. Remember, type 2s have a relative insulin deficiency. It's not enough for the demands of their body. Whereas a type 1 has an absolute deficiency. They don't make any insulin at all. And obviously, insulin resistance is the big problem here. Decreased glucose transport in muscle, making our liver produce a lot of glucose, which is going to in turn further raise our blood sugar and breakdown of fat, which is going to put more sugar back into the bloodstream. Here's our picture again of the ways we can alter our blood glucose. Obviously, stop eating for the first one. Easy way to change that one, just don't eat the sugars. You don't have the carbohydrate intake. These things on the bottom is where the meds come in. And when we go through the classes of medications, think about what area are these meds going to attack? Where are they going to have their effect? Are they going to stop the liver from making glucose? Are they going to stop or enhance the peripheral uptake by our tissues? Like, where is the way we can get rid of this glucose? Obviously, genetics play a very big role with regards to type 2 more than type 1. Eventually, this evidence for beta cell failure, insulin resistance, start leading that cascade where those target tissues are not going to be as sensitive to insulin anymore, and you require more insulin to get the same job done. Insulin concentrations are usually high in the beginning, higher than normal, and then they gradually will start decreasing if the patient doesn't take care of themselves. The defects of type 2 occur with a diabetogenic lifestyle. High calorie intake, a lot of processed foods, inadequate caloric expenditure, you're not exercising, all on a susceptible genotype that will make you become type 2 diabetic. Hyperglycemia, less related to macro, but more on the microvascular. Eyes, kidneys. Those are the big things. The leading cause of kidney failure is diabetes. I think the second or third leading cause of blindness is diabetes. So it affects other things, not so much that. And obviously, know about your cardiovascular risk factors. So all those things are going to become important when it comes to education of these patients. The risk for cardiovascular disease begins prior to the development of hyperglycemia because of all the insulin resistance that's going on with the obesity. So there's this ticking clock hypothesis of complications, which means if you diagnose someone today with diabetes or pre-diabetes, we know they've probably been pre-diabetic for many, many years, which means all these things, especially the risk factors and microvascular risk, start earlier than when you actually saw the patient today. They've been having these problems for a long time. They're just now getting symptoms from it that lead them to come to the office and see you. So microvascular risk is at the onset of hyperglycemia, but the macrovascular risk, heart attack, strokes, starts prior to the diagnosis. Epidemiology, 86 million Americans have pre-diabetes. We know a lot of them will go to full-blown diabetes later. 33% of age adults 20 years and up have diabetes, or pre-diabetes at least. We know 90% are type 2, the rest are type 1. And here's looking at by ethnicity. Non-Hispanic whites have the highest prevalence of diabetes compared to American Indians and Alaska Natives. Wait, am I reading? Oh, it's backwards. Alaska, yes, these have the highest. Non-Hispanic whites low. Age. No. Takes a second to get this one. Usually diabetes was thought to be just an older adult disease, still greater than 40, but obviously with the childhood epidemic with obesity coming, the ages of onset are going lower and lower. 5,000 new cases of type 2 in people under 18 each year. More type 2 in kids now being diagnosed than type 1. So type 1 used to be called juvenile diabetes or juvenile onset diabetes. They can't call that anymore. Well, because that was type 1, but now type 2 are becoming, or kids are now becoming type 2 diabetic. And you can't say juvenile onset because it means type 1. So now they got rid of it. It's either type 1 or type 2. And more kids are being diagnosed now than before. Here's our age ranges again. 60 plus has the biggest category. Under 20, very, very small. But obviously this is starting to peak up because of obesity rates. Mortality, morbidity. Leading causes of morbidity and mortality in the United States. 2/3 of people are going to die from a heart attack. Okay, so these macrovascular complications. Men with diabetes have a 2-fold increased risk for coronary heart disease. Women have a 3 to 4-fold increased risk. Okay, screening for diabetes. Here's like a little big sheet you can use. You just fill in the boxes and obviously looking at age, because we know age is important with that. We have men get a point, women don't get a point. You don't have to know this on your exam. Again, just screening things. These are usually in the offices, little papers. You can pull it out real fast and do it. Women with gestational diabetes. Remember, if they have gestational diabetes, 75% of them are going to have full-blown type 2 later in life. Here's our genetic history. We know that genetics play a big role with diabetes. High blood pressure, physically active, and weight status. Now we're looking at your cardiovascular risk factors to see what's your risk of developing type 2 diabetes. So screening, all patients at age 45 should start being screened with what test? A1C, passed mine, got a 75. Good, right? You don't get that joke? I'm making a joke about your exam being a 75 to pass. If I had a 75 on my A1C, I'd be dead. Like, or walking sugar. No, so 6.5 and above, you're diabetic. Mine was 5. I thought that's good. Real low, 5. Real low. I got space to eat more sugar now, right? Pre-diabetes, look at your BMIs. If the tests are normal, 3-year interval. So once you're good, 3 years, check it again. These are all the same. I'm not going to repeat all this stuff. Know the numbers: 126, 6.5, and 200. Remember those numbers. 6.5 and above, you're diabetic. Below, you're pre. 100 to 126 is pre-diabetic. Anything above 126 is just diabetic. Okay. And then 200 for either a fasting or a symptomatic blood draw. So if you come in and your altered mental status, you're like drinking water like crazy, and you're having symptoms of diabetes, you can do a random sugar then and see where it's at. So here we go again, all the same numbers. Type 2, again, at 45, and if everything's normal, 3 years. And what you can do, fasting plasma glucose, your 2-hour plasma glucose for that glucose tolerance test, and A1C, which we mentioned. So these are all appropriate screening tools for diabetes. If they have diabetes, treat your other risk factors. You can't forget blood pressure and cholesterol. In cardio, did you guys go through management of blood pressure and cholesterol with regards to a diabetic patient versus a non-diabetic patient? You're a lot more aggressive with a diabetic patient than you are with a non-diabetic patient. And consider any testing for type 2 diabetes in overweight, obese children with 2 or more additional risk factors. So here are the risk factors when you want to test a child. They already have a high A1C, our genetic factors, our ethnicity factors. Any woman diagnosed with gestational diabetes gets screened. Any history of cardiovascular disease, high blood pressure, here's your cholesterol levels. You notice, what are they looking at for your cholesterol? And HDL. Where's the bad one? Where's LDL? We don't really look at that. We do later on, but having low HDL is worse than having a higher LDL. Trigs usually go up with sugars. The same way you do a glucose tolerance test and you drink the drink and you see how your sugars do, you can do the same exact thing with triglycerides and you'll see them go up as well with that sugar drink. So they usually go up together. Women with polycystic ovarian syndrome are risk for diabetes, obviously sedentary lifestyle, and anything else with insulin resistance. These are risk factors for prediabetes and type 2. In children and adolescents, overweight plus any 2, family history, the race issue, any signs of insulin resistance. What are some of the dermatologic signs of insulin resistance? And you can throw the dirty, like on the flexural surfaces. What else? Any type of a candida reaction in the mouth, overgrowth. They love the sugar. They go crazy with the candida with the diabetes patients. And then various other lipomas and different things, all the different excess trade. And obviously maternal history. Because if you were a baby and your mom was gestational diabetic and you were developing in that, you were kind of already primed to be a diabetic later in life as well. You've been overloaded with insulin while you're in the womb. A lot of insulin there kind of starts your resistance then anyway. Age of initiation, 10 years or onset of puberty. So when did it start? Frequency, do it every 3 years again, and your same testing screening. So as long as everything is good, they get 3-year window to wait. Presence of diabetes should be considered in any obese patient. And again, genetics, ethnic groups, and whatnot. So there's a lot of repeat. So who should be screened? Look at your risk factors. They're getting blood work done anyway. If you get a BMP, glucose is going to be there anyway. Just add on an A1C. Clinical presentation. Again, most are going to be asymptomatic for years. They don't know they're pre-diabetic. They're going to be in that state for like 10 years. Other symptoms from hyperglycemia, blurred vision. Okay, they get blurry vision and comes and goes. Ask when their blood sugar spikes. Is what, or have them check their blood sugar when they're having blurry vision. If their blood sugar is like 250, that may be a reason why they're having blurry vision. Lower extremity paresthesias or that yeast infections. That's where that candida loves to play. And the asymptomatic state does not mean it's not affecting them. It just means they're not having any symptoms. They're not feeling anything. But that does not mean that internally they're not destroying their beta cells. They're not making them harder for the insulin to work. So that's what's going on here. Physical exam findings, again, obesity, hypertension. They may have some eye hemorrhages, exudates. Here's our acanthosis nigricans. Neuro, some sensory issues. Feet could be dry, some atrophy in the legs and the feet. Claw toes, maybe some non-healing ulcers. There's no blood supply to the legs. These ulcers are not going to heal. Okay, we're flying through this because a lot of it's the same. The only thing that's going to change really is just the treatment when we get to all the meds. So we're trying to get into the meds as fast as possible. Plasma glucose, where we do it. Serum measurement may be lower than plasma. So we try and get serum or plasma glucose. And again, 6'5", 126, and 200. Screening, we already went through. Well, other screening, urine microalbumin. Every patient coming into an endocrine clinic, if they have diabetes, do a dipstick on them every time. Have them do a urine sample. See what's going on. Know what's going on with the protein level in the urine. If you see protein in the urine, that means you've had damage to the kidneys. They should not be there. So if abnormal, which is greater than 30 milligrams of protein per gram of urine, should be performed. Normal albumin excretion is less than 30. So anything between 30 and 300 is considered microalbuminuria. We're setting small proteins getting through that little sieve in the kidneys because of all this kidney damage due to the glucose. And confirm persistent microalbuminuria, 2 to 3 samples over 3 to 6 months. You can't do it off of one. You need a confirmatory sample later on to show that these are still elevated. You can't do it off of one. And greater values can be detected by standard protein dipstick and considered for macroproteinuria. But basically, we're looking to see how much protein is in there. 30 to 300 is microalbuminuria. We're getting too much protein in there. Our insulin levels are going to be high in the beginning and then gradually wean off. These things right here are only in type 1. Antibodies to insulin, antibodies to the islet cells, or this glutamic acid decarboxylase, those are all pathognomonic for type 1 diabetes. Okay, treatment. Here we go, finally. So individualized glycemic targets. So you can't really, we have like one prescription for all, but you have to monitor, tweak it for people. What are their side effects? What are their goals? Like, do they want to lose weight? And certain things you want to do, but you have to know what your patient's goals are. Diet, exercise, and education are the foundation for treatment. It has to be diet. You have to cut the sugar that you're eating. They have to exercise, be less sedentary. And obviously, patient education is very, very important for these patients. Metformin is the optimal first-line drug unless contraindicated. So any new diabetic, just remember metformin 500 once a day. You start 500 once a day. You can go up to 1,000 twice a day. But as you learn from Dr. Wood, you start low and slow. Give them 500 once a day. Then you can go to 500 twice a day. Then you can go to 1,000 in the morning, 500 at night, and then 1,000 morning and night if they need to. Then you've maxed it out. You can't go any higher than that. Once you've maxed out metformin, then you can add 1 or 2 additional oral or injectable agents. Goal of minimizing adverse effects. What's the major adverse effect we're trying to avoid all the time? Hypoglycemia. We don't want your patients passing out and falling. Ultimately, insulin therapy alone or with other agents may be needed to maintain tight glucose control. What are we looking at? How do we know where we've gotten your levels where the medicine where they're supposed to be? What do we monitor? A1C. As long as the A1C is coming down, we're okay. If it keeps going up, we need to increase the dose because they're not going in the right direction. Where possible, all decisions should involve the patient with a focus on patient preferences, needs, and values. So if you have a patient population that has certain dietary restrictions, give them food that helps them with those dietary things because they're going to follow that diet easier. When I worked in cardiology here in Orlando a long time ago, he was an Indian doctor and he would have like recipes for like different types of Indian food that would have less salt in it or other ingredients to help with diabetes or high blood pressure, cholesterol. But again, he had a large Indian population, so it would make sense for him to offer foods that their culture would normally eat. If you never eat these foods anymore or never ate these types of foods, you're not going to start doing it either. So work with their culture, what they enjoy eating, and alter it from there. And cardiovascular risk reduction obviously is the goal. So goals for caring for patients. get rid of their symptoms, reduce microvascular risk, reduce macrovascular risk, and get control with your glycemic control. So care requires appropriate goal setting. Goals are very important. They help people stay on track, but you have to make the goal obtainable. You can't make it so hard that they'll never obtain that goal. If they need to lose weight, don't say, I need to lose 30 pounds in 3 months. It's not going to happen. Say, just come back in 3 months and lose 10 pounds. Some obtainable goal they can do. They'll feel better about obtaining that goal, more likely to follow along with lifestyle modifications. And obviously, self-monitoring of blood glucose, they have to check that regularly, diet, exercise, medications, and whatnot. So you want to have not just glucose alone, you have to make sure that not only the glucose, but your lipids and your blood pressure are also controlled as well, not just the glucose. A1C, at least 2 times annually in patients who are controlled. So these are controlled, it's twice a year. Check your A1C. Quarterly in patients who are not meeting glycemic goals. They're also point of care, which means in the office, they can do an A1C in the office now. With a finger stick, they can get A1C in like 15 minutes. They'll get you the results versus going to the hospital and getting the full lab. But I don't know how sensitive they are now. Accurate, but they're close enough in the office. This chart, you don't need to memorize it. Again, I don't make you memorize these things, but what's the concept I'm trying to make you understand here? If you look at on this column, it's all the A1Cs. So if your A1C, let's say, is 9, that means that your average plasma glucose is around 212. Average sugar, if your A1C is 9, it means you're averaging over 200 milligrams per sugar every morning. That's what's going on all the time. If you're at 6, you're at 126, which is our cutoff. So you can see here again, the higher the A1C correlates to a higher glucose all the time. This weekend, I'm doing the health screenings up in LA. All these people, they think, oh, I'm just not going to eat the night before. I'll come in fasting and my A1C will be okay. It's not, it won't change. Your fasting glucose will be low, but your A1C, you can't out-cheat an A1C. You can't out-cheat a cholesterol test the night before by not eating. You can cheat the glucose reading, but not the A1C. Goals in adults. The goal is to get them below 7%. If they're higher than that, get them low. More stringent goals, less than 6.5, if they can do it without significant hypo events. So you want to get them as low as possible, but you want to prevent them from having a hypoglycemic episode. So you're kind of being very careful with the meds. And less stringent goals, if they have very, very sensitive hypoglycemia, they're very symptomatic, limited life expectancy, or anything that makes it difficult getting below 7. So 7 is the main one. A1C and cardiovascular disease outcomes. Again, all these studies are just showing you lower the A1C, you lower the risk reduction for cardiovascular complications. So that's why I always harp on you guys. The number one treatment is always get the sugar under control. By any means necessary, get it under control. Again, these are the goals you want to get to for adults. Less than 7, here's your pre-prandial, 80 to 150 again. And your goal, we don't really measure it that much, but that 2-hour peak, be less than 180. But the first 2 are definitely easily measurable to do. Goals, again, get the A1C down, reduce your risk for all other complications. These are just more trials that just prove again why we're trying to get to 7, why we're trying to get to 6.5%. These trials have all shown reduction in risk when you reduce the A1C. Monitoring of glucose. Anyone who is taking an insulin or an insulin secretagogue, you have to monitor for glucose. If you're taking metformin oral by itself, you do not need to be as strict with glucose. Maybe 3 times a week in the morning, that's it. You don't check it all the time. But if you're taking insulin or anything that secretes you to, or promotes you to secrete more insulin, the risk for hypoglycemia goes up. You have to watch out for those people. The optimal frequency is not really there. No one really knows, but it should be enough to facilitate the goals that your patient needs. Any patient that is on any medicine that does not cause hypoglycemia, you don't need to really be on this as stringent again. Metformin, glitazones, glucosidase inhibitors, these are examples of these drugs do not cause hypo events. So you don't need to check it as often. Okay. They help guide treatment decisions because when you see every patient, when they come in to see you, you want to check their glucose logs. And you want to see how they're doing in the morning. What's it look like? What's their average in the morning for fasting? See what's going on. So they're going to need a lot of test strips. Again, when should they check? These are the big ones: prior to meals and at bedtime. If they're going to go exercise, they can check it before they start. If they suspect they have low glucose, check, do a finger stick. If you treat a low glucose, you have to continue to monitor them to make sure their glucose levels come back up. So if you help someone with a hypo event, you should be checking them afterwards to make sure the glucose is coming back up again. Any critical tasks such as driving and occasionally postprandial. Lifestyle modifications. Diet is just watch the food that they like to eat normally. Don't go crazy with like, macros and this and that. I think I talked with some of you guys where there's this guy on YouTube, whatever, who says like he has a glucose monitor on. He's like, I'm going to eat foods in different orders to see what it does. That does nothing. Your stomach just hold on to the food for 4 hours anyway. Where's it going to go? Glucose gets stuck there. No matter what order you eat the food, it's all going the same place. But caloric restriction is the most important thing. What, 600-pound life? The doctor's like, you don't need to eat. You're like, I'm starving, I'm not eating. Like, no, you're fine. You'll be okay. And cut out on saturated fats and your simple sugars. Nutrition therapy, again, getting down the processed foods, nutrient-dense foods, very, very good. Helping with achieving body weight goals, glycemic control, and whatnot. Again, personal and cultural preferences. What do they like eating? Find ways to make them still eat the same food, but in a more healthier way. Non-judgmental messages about food choices. Okay, don't make them feel bad. Just say, how can we make better choices? Again, practical tools. Have a piece of protein. It should be the size of your fist. That's a good thing. Another thing for like protein is like 1 gram of protein in your food for every kilogram of your body weight. It's a good marker to try and hit for protein as far as not go crazy with the macros, but it's an easy way to look at. Medical. Obviously, it's individualized. Not everyone is the same. You have to kind of treat everyone different. If they're on a flexible insulin program, educate on carb counting. We talked about that last week. That insulin carb ratio. That's where carb counting is important. You got to know how many carbs you're eating and what your ratio is. For people whose daily dosing is fixed, having a consistent pattern of carb intake helps as well. So remember we did the prandial dosing in 2 ways. One was just doing that formula and you have your 3 doses and just give it. If they eat the same food every day, that's fine because it's the same insulin every day. But if their diet changes every day, then be more strict and use your preprandial glucose sliding scale, add it to the amount of insulin for the food that you're eating. And that gives you a more sensitive control for this. So healthy food choices and portion control, very important. Energy balance, weight loss is important. So lifestyle modification and reduction in calorie coming in will help. Even little bits will help with obese patients. Just little bits here and there, they'll lose weight fast. The biggest thing when it comes to food with diabetics is not so much it's when they're eating it and for what purpose. If they're having a hypo event, you don't want to give them food with protein. Give them simple sugars, get in the blood fast. But if they're having normal meals, having high protein delays the sugar being released into the blood. But the big thing is also glycemic load. So we look at our, yeah, it's coming up. Be careful with sugar sweetened beverages. They love to hide sugar in a lot of food. Anything that says fat free or sugar free is probably bad for you. Like sugar free, especially because they have to still make it palatable. You ever have non-dairy or non-fat ice cream? Tastes like garbage. Why? Because fat tastes good. And when you take it out, it doesn't taste good. So they have to either add a bunch of sugar back into it for these non-fat foods, they add a bunch of sugar, or like the synthetic sugars. So be careful with these like fat-free or sugar-free stuff. Is it really that healthy? There's different types of diets, the Mediterranean, DASH, plant-based diets. You will have a whole course over the summer on nutrition with Professor Green, who is a registered dietitian. So you're gonna learn all this stuff about great diets for different purposes. So this is the glycemic index. The key is to give your patients food that have low glycemic index. So if you look at like grains and starches, I mean, they're high, but 55 is the cutoff. So rice bran, cereal, spaghetti is there. You look all the way down the bottom, here's your white bread. Really, really high glycemic index, which means all that sugar is gonna go right into your bloodstream when you eat it. High spike in glucose results in what? What happens next? Insulin's got a spike to come deal with all that. And then you get your crash afterwards because all the insulin took all the sugar out. And then you crash. And then you feel hungry again. Then you start eating again. And then your insulin spikes again. That's what happens when you eat so much. Your spikes go crazy. Look at your fruits. Pineapple, watermelon on the bottom there. Very, very, very high glycemic index. Grapefruit's very low. Apples. Dairy, your yogurts, and obviously your proteins. So different foods. Proteins. When you eat protein, glucagon is going to come out too. Kind of suppress the insulin. We don't want too much insulin coming out. So this is the really big thing here. Don't give high protein food people who have hypo events. Those boost drinks, they say they're for diabetics, they have protein in it. Those are meal replacements. So if they're not eating, they can drink that shake and have all the calories in it. You can't give that if they're having a hypo event. You got to give them like orange juice or a candy, yes. Still the protein that's in it, it doesn't matter. The protein is going to stop from the sugar getting into the bloodstream. So no protein, straight sugar. Dietary fats, omega-3s are very good. Supplements, no clear evidence that any supplements really help with diabetes. So just really nothing there. Alcohol, avoid it, not good for diabetics. Sodium, obviously we have to be careful for hypertension, so be on a sodium restricted diet. Non-nutritive sweeteners, sweet and low, all those little things now. They are substituted for sugar, but what happens is they're generally safe, but they can actually cause problems later on. So like Diet Coke doesn't have sugar in it. It's got other things in it. Non-nutritive sweeteners that can cause a lot of havoc. You put like a bone in Diet Coke after a while, see what happens. Mediterranean diet, low fat is the main one with this one. Again, it helps Mediterranean diet. The biggest thing with these diets, to be honest, the minute you start looking and watching what food you eat, you're going to stop eating as much. And that's what a lot of these diets do. They just kind of force you to look at what you're eating, and then you realize, oh my God, I'm eating all this food. I can cut back. But they help. Physical activity, again, helps. Get them low and start them slow. Again, find ways to increase activity. Park farther away. Tell them to park farther away when they go to the mall. If they still watch TV at home, they can walk while the show is on. When the commercials come on, they can stop. They have a little bit of a break. And then when the TV comes back on, they start walking again or biking. If they're morbidly obese, you have to be careful for weight-bearing activity. They're not going to be able to walk as long. If they have access to a pool, they can just walk back and forth in the pool. There's ways to find activity. Children need more activity than ever. They're not getting it enough. Recess is gone in schools. They don't do anything. There's nothing keeping them. Not as much. Eli never had recess. They don't have like free stuff anymore. It's in class all day. I don't know. So we're very sedentary. Keep moving, keep active. Again, I'm going to do this more in the summer in that complimentary med course. I come back and I do a lecture on exercise with you guys. Once endo's done, I'm done with you guys too. You don't see me anymore. Yeah, I go back to the first years for physio in the summer. Yeah, you go back. Okay, weight loss again. Weight loss helps get the weight off and things will reverse. Obesity does play a role. Obviously, the extremely obese, over 40 BMI. At that point, you got to start looking at lap band surgery and different type of bypass surgery. They may benefit from surgery, from metabolic surgery, diet, physical activity, and behavioral therapy. People who are ready to achieve weight loss. One of the other things you're going to come with when you see these patients, they have to be ready and understand that they have to make a change or they won't do anything. If your patient comes in like, oh, I know what I'm doing, I'm fine, they're not going to change. They're not going to make a change in anything unless they are ready to make the change. So again, make sure that they're ready to go. Keep your goals obtainable. Finally, into the pharmacotherapy with the medications. When you're choosing medications, think about the profiles. Some have an impact on weight. Some make you gain weight. Some will make you lose weight. See these profiles before you start assigning things. Minimize medications for comorbid conditions that are associated with weight gain. The goal here is to get the weight off. Weight loss meds may be effective adjuncts to diet, exercise, and behavioral counseling. If they respond to weight loss medications, you can discontinue medications and consider alternate medications. Okay. Here's our metabolic surgery. Again, they will help. They will lose the weight. However, they can relapse and some of them can gain all the weight right back. Usually what happens is, again, if you make your diet a goal, I'm going to say, I'm going to lose 30 pounds. And then you lose the 30 pounds and like, oh, I'm going to reward myself. And what do you reward yourself with? Food or a cupcake or something that you cheat with. And then you start over again and gain weight back. Okay. So you have to, that's why it's not a diet, it's a lifestyle modification. It's total change. Anyone a BMI over 40, recommend metabolic weight loss surgery for them. It will help. And they should be performed in high volume centers because Celebration, Advent Health Celebration is where the bariatric surgery places. And they have very long tools because you think your normal like forceps or scissors will be able to get there. But when you have inches of fat to get through, those tools aren't long enough. So you need a whole separate system. You need obviously bed sizes big enough, walls to get through in the operating room. All those things need to be changed. Obviously, they need to be seeing dietitian after the surgery. Mental health services is very important as well. A lot of the times when people get morbidly obese, it's due to some underlying psychological condition. If you don't treat that underlying psychological condition, you're not going to treat the obesity because you're not solving the problem. They're going to continue to eat stressy or whatever. So you have to keep treating them for that. Adverse effects of surgery, it's costly. There are risks with any surgery, but even more if you're obese. One of the big ones is breathing. You got to make sure you can breathe when you're sedated. And if your neck is so thick, then they're worried about airway. Can we even get a endotracheal tube into your throat. So when you're laying flat. So a lot of things you have to be very careful of. Outcomes will vary. And again, high risk for depression, substance abuse, and those psychosocial issues because you have to treat those as well. And if you watch like 600-Pound Life, you'll see like a lot of them have underlying trauma or other issues that led to all that to happen. Okay. A lot of changing in medication for diabetes the last 10 years, partly because of money pays to treat people for this stuff. New drugs, obviously treating type 2 diabetes. Obviously, still, diet is still the cornerstone of all diabetic therapy. Before you give them medication, you have to talk about food. They have to change their foods. People who are symptomatic may require transient treatment with insulin because the sugar is just way too high. So if you come in with like that hyperosmolar, you're coming in with 800,000 glucose. You need insulin for that. Like metformin is not going to help that. So in that environment, you need insulin. Outside of that stressful time, you may not need insulin. Anyone with an A1C less than 7.5, give them oral agents. They're going to do fine. Usually, when the A1C is greater than 9%, even up to like 10%, that's when you start insulin. So if they come in, their A1C is like 9.5 and they're symptomatic, they got to start insulin. They can't start with metformin at 9.5. They got to be on insulin and bring it down, and then you can take them off the insulin. But they need to get it lower. So here we are again. First class of drugs are the biguanides. This is a very old drug. This is your metformin. So biguanides, metformin. The problem with metformin is it can cause lactic acidosis. Therefore, any patient coming into the hospital, they're being admitted. They're diabetic and they're on metformin. You have to stop the metformin while they're in the hospital. And what do you give them instead? Insulin. Give them a sliding scale. You give them insulin while they're in the hospital. What if they need scans done? What if they need a CT scan done? They need contrast. And they're on metformin. We know the risk for lactic acidosis goes up. Why, risk it? Just stop the metformin. Give them insulin while they're in the hospital. When they get discharged, they go right back on the metformin. So always stop metformin in the hospital. Very, very low hypo events with metformin. So you don't need to do all this glucose monitoring with it. Also, metformin helps with modest weight loss. So it's going to help them lose weight and going to help reduce the amount of blood sugar. So metformin, it's Glucophage is the brand name. Very easy to remember. Glucophage eats glucose. If you're eating it up, it's not in your blood. Don't use it in renal or hepatic insufficiency. That's one of the big ones for it. Or anything with like decompensated heart failure. They can't be on metformin. There are some GI side effects with metformin. It can cause some nausea sometimes, some upset stomach. So if you prescribe metformin and they come back a week later like, oh, my stomach's really bothering me, tell them to take it in the middle of the meal. It'll help with the GI problems. And metformin can be used as monotherapy or with sulfonylureas or insulin. These insulin secretagogues. So metformin by itself, but it also helps with insulin. What does metformin do? Reduces hepatic glucose output. That's the main thing. So the liver is not making any glucose. Remember, go back here. Metformin blocks that. Diet blocks that. And as we go through the other ones, you'll see how the other drugs come in. XR, so it's long, there's once a day dosing, extended release. Again, it's the initial agent for diabetes. Why does metformin, why is it the first line? Efficacy, very easy to tolerate, once a day dosing or maybe twice a day, depending on what you need. The absence of weight gain or hypoglycemia. We know metformin can cause weight loss, and we know it doesn't have anything to do with hypoglycemia, so we're okay there. Low level of side effects, high level patient acceptance. It's a generic drug. It's dirt cheap. You can get like 90 days for like $5 probably at Walmart or Costco. Again, relative low cost. So those are the biguanides, metformin. Sulfonylureas is the next one. These are insulin secretagogues. These are not first line. They used to be, but not anymore. Now it's just metformin is first line. Some examples is glyburide and glipizide. You don't have to know any of this stuff underneath it. Just know those drugs. Amaryl is the third generation glimepiride. So all the I's, I think I have it here. No, I don't. Okay. So anything that ends in IDE are your sulfonylureas. There may be some interaction with the cardiac potassium channel. So there is some issues with heart disease in these patients. And Amaryl glimepiride is the only sulfonylurea approved for use with metformin or insulin. You take them together. Meglitinides. These are short-acting insulin secretagogues, then sulfonylurea. So they end in IDE again, but these are faster acting than that generation was. Glycemic efficacy is possibly less than sulfonylureas. And your example is Prandin and Starlix are the two examples of meglitinides. Short-acting insulin secretagogues. They cause you to secrete more insulin. Next one, alpha glucosidase inhibitors. These inhibit the absorption of carbohydrates. So now we're attacking your intestines. We're going to limit the amount of glucose your body is going to absorb. Titrate slowly. There's some GI issues here. Glycemic control is modest. It's usually more for postprandial issues. Example is acarbose or Precose. This is the first one approved by the FDA. So alpha glucosidase inhibitors block the absorption of carbohydrates from your food that you eat. TZDs, new class of drugs that reduce insulin resistance in the periphery. So now we're attacking the target cells and we're making the targets more sensitive to insulin so they're going to have a better effect. May have some beta cell preservation properties. Only ones that have been shown to slow progression of diabetes, but here's the problem. May induce or worsen heart failure. So a lot of patients with heart failure, you can't give some of these meds. TZDs is the big one. Do not give anyone with any type of heart problem. Just avoid the TZDs altogether. Actose is another one. Again, improves target cell response to insulin without increasing insulin secretion from the pancreas. You're preserving the beta cell function with this medication, which is why TZDs have been shown to help maybe delay the progression because it's preserving beta cell function. Increases insulin-dependent glucose use in skeletal muscle. So again, we're not using insulin. Just like after exercise, your muscles will absorb it. Same thing here. And will lower your trigs. So again, cardiovascular risk factor modification. Avandia is another TZD. Again, just know the names. They all act the same. Anything specific for a drug, I will mention to you and let you know what's important about it, but otherwise, they're all going to act the same. This is just talking about, again, anyone with heart issues, just avoid. It causes a lot more problem with it. Incretin mimetics. Here's your GLP-1 receptor agonist. They mimic endogenous incretin, glucagon-like peptide GLP-1. Okay, so it stimulates glucose-dependent insulin release. Why is that important? Glucose-dependent insulin release. You're only going to release the amount of insulin that you need for the amount of glucose that you have. Whereas other ones, you just do it. It just does whatever it's going to do, and you have to be careful with your eating to offset any risk factor from hypo. So it helps insulin without having to cause the pancreas from doing it. Reduces glucagon, slows gastric emptying, so you don't get that massive dump of glucose into the bloodstream. And it's this slowing of gastric emptying is what people are using it for not eating to lose weight. Attain modest weight loss, and it's a sub-Q injection. Byetta is also an incretin mimetic, mimics glucose-dependent insulin secretion and other things as well. So what does it do? Enhances secretion from pancreatic beta cells, suppresses our glucagon secretion, and again, slows gastric emptying. So these are the important things that all these incretin mimetics do. Slow gastric emptying, glucose-dependent insulin release, and suppresses glucagon. Let's talk about different things with exenatide, different titrations, but again, look at the cost, what insurance your patients have, what's going to benefit them the most. Victoza is another one. Again, just remember the names, know the class of what they belong to. They all do the same thing. Long-acting GLP-1s are given once a week. Trulicity, obviously the other one's there now too. You do it once a week. Unclear if they're any more effective than the short-acting, but you can do long-acting as well. DPP-4. DPP-4 inhibitors, it's a long word for it. Just remember DPP-4. What does it do? Degrades active peptides, including GLP-1 and glucose-dependent GIP. So that's what DDP-4 does originally, is going to break these things down. But we want these things around, right? We like GLP-1. We like GIP. We don't want them broken down. So we give a DPP-4 inhibitor. We prevent that enzyme from doing its work, and it's going to allow for better insulin control because nothing's going to oppose it. Can be used as monotherapy or in combination with metformin. Once daily, weight neutral. Not going to make them gain any weight. And 3 is gliptins are the N word. So anagliptin, linagliptin, and vildagliptin are your DPP-4 inhibitors. Januvia is another big one. So just remember the names, the class, what they do, what their profiles like. Here's our Onglyza. Again, DPP-4 inhibitors increase the concentrations of our incretin mimetic, the hormone. That's the only goal of this, to allow those to stick around longer. SGL2s, selective glucose transporters 2, increase urinary glucose excretion by lowering the renal threshold. Remember, let's go all the way back to physio. And we went to those, we did renal, we talked about glucose transport, how we can maximize those glucose transporters, and once you maximize it, everything left over goes in the urine. In this case, with these drugs, they lower that threshold, so it's even lower. So you're going to dump more glucose into the urine. We don't care if it's in the blood, we want to get it in the urine. So this drug and these types of drugs are going to increase urinary excretion of glucose, getting it out of the blood. And these are the examples of these ones. Amylin analogs, and they mimic endogenous amylin. Remember, amylin is released with, what is it released with? Insulin. They go together. So if you're type 1, you don't have any amylin. Type 2, you may lose it later on. But again, delays gastric emptying, decrease postprandial glucose release, and helping with appetite. So these are the effects of amylin. So one of them is a Simlin pen, make it easy to remember. Simlin, amylin, we know what it does. Sub-Q injection and prevents postprandial increases in plasma glucagon. Glucagon is going to raise your sugar even more. Promotes satiety as well, so they're going to feel full and not want to eat. And obviously, insulin is the final one. Follow the same rules we did before. Obviously, if they're not controlled, they're not changing their diet, their sugar levels are way high all the time, they're going to get worse and worse and worse. Insulin obviously is very variable, and you have to everyone gets their own prescription. Metformin is a great thing to use with insulin. They go together very, very well. So what metformin does is it makes the insulin more sensitive in the peripheral tissues as well. So not only is it going to stop the liver from making glucose, the metformin also makes the insulin you're taking work better. So you can do them both together. Long-term use of metformin may be associated with B12 deficiency. So check your B12 levels on these patients as well. If non-insulin monotherapy at maximum tolerated dose, meaning they're on metformin, 1,000 BID is the maximum tolerated dose for metformin. If they're on this and their A1C is still high, then you add a second agent, a GLP-1 receptor agonist, or even basal insulin. And again, patient-centered approach to all medicines. Don't delay insulin in patients not achieving their glycemic goals. Talk to them and say, this is a bridge. Let's just use the insulin for 3 months. Let's see if we can get things under control. 3 to 6 months, see how your A1C is doing. Once it gets controlled, we can back off on the insulin. Don't scare them into thinking it's going to be there forever, but again, give them the chance to say, you can do it on your own and see what they do. It's a progressive nature, again, if they don't take care of themselves. Avoid using insulin as a threat and don't use it as a failure or a punishment. But again, say like, let's try and get you across, do some lifestyle modifications so they can get off of it. This is just looking at cost of things. You can see here's metformin. It does say average is $84, but I know at Costco and they're a lot cheaper. Where's our, here, GLP-1 and receptor agonist. Look how much they're going for per syringe probably. So if they have the money, yeah, they should, sure, they can do all this great stuff. But if they don't, stick down here, metformin, sulfonylureas, and so forth. Okay, complications, we're gonna deal a lot more on Thursday, but they should always get eye exams, yearly microalbumin checks, ideally at every visit, and foot exams at every visit. Make sure they're getting any neuropathies. Obviously, heart disease is a big risk factor. We have to make sure they're very aggressive with these things. CVD is leading cause of morbidity and mortality for those with diabetes. Largest contributor to direct and indirect costs. Yes, you have diabetes, but now you have a heart attack. That's an indirect cost of the diabetes because you wouldn't have had the heart attack if you didn't have diabetes. So obviously our hypertension, dyslipidemia are going to be very important here. So goal, ADA, American Diabetes Association, BP goal, less than 140/90. If they already have proteinuria, it means the kidneys are already damaged. Now we have to go even lower, 125/75. Get that blood pressure down because they're already showing signs of renal involvement. You can give ACE inhibitors, ARBs, diuretics, beta blockers, and calcium channel blockers are all fine for a diabetic patient. Obviously, check blood pressure. You do vitals at every single visit anyway. Targets 140. If they have risk factors, just lower it. Keep going lower. Diastolic less than 90, but if they have risk factors, 80 or even less than 75. Okay. Preference is ACEs because renal protection in patients with diabetics. So your first line is going to be like lisinopril, enalapril, those ACEs. You give ARBs too. They both work on the same thing, just different parts of the chain. Many are going to require multiple agents. You have to add on a bunch of different ones. They may not just be on one drug. They're going to be on a bunch of them, all to control blood pressure. So ACEs and ARBs are very good for that. Dyslipidemia, again, high trigs and low HDLs. You see a lot with type 2 diabetics. Obviously, we want to lower all cholesterol, so that does obviously we need to lower LDL as well. So if they're not taking statins, you do a screening lipid profile at the diagnosis of diabetes, get a lipid panel, then see what's going on. Initial evaluation or every 5 years afterwards. And if you start any statin, get a lipid panel to see where you are, where you start. Lipid management, obviously weight loss, reduce saturated fats, trans fats, cholesterol intake, increase omega-3 fatty acids, fiber, plant sterols, and obviously physical activity is always important. So trigs, if they present with these things, you have to be very, very strong with your lifestyle modification. So trigs greater than 150, HDL less than 40 in men and less than 50 in women are risk factors. When should you start being treating with statins, depending on what the severity of their risk factors are and their age. So obviously, the older they are, the more risk factors, the more intense you need to be with your therapy. What else is there? So how do they respond to statins? A lot of times patients will get cramps with statins. Just monitor them for that. There are combination drugs with lipids. You can always do different ones for that. Important here. No statins in pregnancy. Statin and niacin together, no additional cardiovascular benefits than statin alone. So, but what's the side effect with niacin? Flushing, they get very hot faces. They won't not want to take it. So if they're on high intensity statin therapy, they got to lower LDL by 50%. You got to give atorvastatin or rosuvastatin. The only ones that are strong enough. What are these two? What's the brand name? Lipitor and Crestor. Okay. Lipitor is atorvastatin, Crestor is rosuvastatin. These are the newer ones. They're very potent. That's why they're needed when you have a very high reduction in LDL. You need to go with the bigger guns. The weaker ones, where is it? Simvastatin is very weak. That's Zocor. Pravastatin is very weak. That's why it's up to 40 to 80 milligrams to have a lower reduction than 40 to 80 milligrams of atorvastatin. So it's a weaker drug. But again, depending on what you have to do, pick the stronger ones or the weaker ones. And even if you wanted to go with your Crestor and Lipitor, just start them on a lower dose. That's fine too. Nephropathy, obviously they get end-stage renal disease, keep blood pressure and glucose under control. Obviously, ACE inhibitors, always good to start with when it comes to renal disease. Antiplatelet agents, risk factor modifications, you have to worry about these platelets as well. So just give them baby aspirin. If they have more risk factors, then up it to the full dose. Aspirin is not recommended for any type of cardiovascular disease patient with diabetes because there is the potential bleeding will offset the benefit of the drug. So always look at your risks and benefits with regards to any drug, especially ones that have very serious bleeding problems. If they have diabetes, obviously clinical judgment is required. Aspirin therapy, secondary prevention in those with diabetes and a history of cardiovascular disease. If they have an aspirin allergy, just go to Plavix. And you can try dual platelet if you need to. And screening, you've already done all this stuff already. So it's all routine screening. When do you do it? It's all repeat. Treatment, again, with what they need. Again, there's a review from cardio, nothing's new here. Treatment, here is where you avoid your TZDs. Again, they're in heart failure. They have heart problems. Don't give any TZDs. In patients in type 2, stable CHF, metformin can be used if renal function is okay. Complications, retinopathy. So make sure they do yearly ophthalmologist exams. Neuropathy, so you do your foot test every time you check that monofilament test to avoid that numbness and stuff. Peripheral vascular disease, claudication, non-healing foot ulcers. Again, there's no blood supply, not going to heal. Smoking cessation, very important, correction of your side effects. And last little bit on patient education. It is not satisfactory just to provide brief instructions. This is why we have diabetic educators now, because it requires a lot more time than you have. You guys did your OSCEs yesterday, you had 25 minutes. Imagine you had to deal with all of this now. Not enough time. So you don't want to just give pamphlets and say, go on your way. You need to be a lot more involved than that. So there's a team of providers that are around, the diabetes educator. There may be some non-physician health professionals involved as well, nutrition. And then again, it's not one or two encounters. It's a lifetime. You always want to educate every visit they come in. So we are done with type 2. So on Thursday, we'll do all the complications. And then next week, we'll have a review. The exams on Friday next week. Okay, I'll see you all on Thursday. Let's be a little bit. They're all the same.